This is a lab video. We're going to cover exercise 7, specifically 7.2, which is the advanced skeleton. We're also going to cover exercise 8, which is the joints. And we're using our lab manual. If you're looking for the page, it's page 79. This is the some images that I just wanted to go over the basic skeleton, which we already learned. And so you can pause this. I probably recommend having your textbook out so that you can learn these as we go through the skeleton. Again, we already learned these: coxal bones, the ilium, the pubis, and the ischium in the back. So these are some basic bones we've already learned, the major skeletal bones, and we're just going to add some advanced bones when we get to the rest of the lab manual. Again, if we go down to the lower extremity, we've already learned the femur, the tibia, the fibula. A lot of students get those confused: tibia, fibula, tarsal bones, metatarsals, and phalanges in the foot. If we go back up to the hand, we've got the carpals and the wrist and the hand. We've got metacarpals and phalanges. So if you're wondering, well, what does advanced skeleton mean? Well, we can learn individual names of carpals and tarsals. We can learn parts of bones such as the femur, where there's the head, as well as this lateral notch called the greater trochanter. So that would be advanced, is learning very specific parts of the individual bones. For example, tarsal bones we're going to learn are the talus and the calcaneus. And you can see there the talus at the ankle and the calcaneus at your heel. So those are examples of advanced, and we'll go through those one by one. We're going to start with the skull, since that's where we ended last time. And the skull bones that we've already learned are here: the mandible, maxilla, frontal bone, parietal, occipital, and related bones. So these are the ones we've already learned. Again, you could always pause this if we're going too fast, or you want to label your lab manual or color code it. Some new ones that we haven't learned: the nasal bones and the sphenoid bone sticking off to the side there. You can see it better from other angles. So we're going to go through the advanced skeleton now, and we're going to start with the skull, page 84. So a lot of these are nothing different. We already learned them. And then you'll get to a bone like occipital bone, where it's got an extra part that you've got to learn that's part of the occipital bone. Remember, the occipital bone is that posterior, sort of inferior bone at the back, and so to see it best, we're going to look with an inferior view. So now we're staring at the bottom of your skull. We've removed the mandible so that we can get a better view. So the mandible's gone. There's your occipital bone. The occipital bone has a hole in it, and so that's your spinal cord can actually communicate and attach to your brain. That hole is called the foramen magnum, if you want to think of it like the biggest hole in the skull. So the foramen magnum is part of your occipital bone that allows for your spinal cord to go up and attach to your brain. So again, that's part of the occipital bone, and so that's what we mean by getting advanced. So we'll just check these off as we go. The temporal bone has 3 prominent features that we want to learn, or parts. So again, our temporal bone, you just find your ear hole, and it's all that bone right around there. One of the things you'll notice is that the temporal bone makes part of an arch. It's called the zygomatic arch, and the temporal bone is the posterior half of the arch. The other thing you'll notice in your temporal bone is the external acoustic meatus, or sometimes called the external auditory canal. That's a hole that allows you to hear. There's also a notch where the mandible sits. That's called the mandibular fossa. I just wanted to point out that the front half of that arch is the zygomatic bone. So the anterior one half of the zygomatic arch is the zygomatic bone. So together those make up what's called the zygomatic arch, which is pretty easy to feel if you go from your cheekbone back towards your ear. And it's easy to forget about all those tissues stuck on here when you're just looking at the bones, but don't forget about the cartilage and skin and things stuck on there. Okay, so there's our temporal bone. And again, it's got this little indentation in it. That's called the mandibular fossa. I like to think of it sort of as your jaw socket. The mandible sits in there, and the mandible has these little prominent sort of rounded edges up at the top, and that mandible fits right in those mandibular fossas, making the temporomandibular joint on either side. Okay, so that's the temporal bone. The next bone is the sphenoid bone. That's a new one for us. It's a little hard to see from some angles, but your sphenoid bone you can see really well. We already sort of mentioned it, as you could see it laterally, but it's probably much easier to see if you look at the posterior eye socket. Sometimes we could just call it the orbit. So if you look at the orbit, the posterior wall is the sphenoid bone, so it's behind your eyeball. And you'll see some nooks and crannies and circles and holes in it. That's so things like arteries, nerves, and veins can come through. Anytime you see holes in your skull, you can think about big stuff, little stuff going through, soft stuff like arteries and veins. There's that lateral view that I mentioned of the sphenoid bone. That's a little harder to spot, but don't forget that. It's sort of surrounded by bones we've already learned, frontal bone, parietal bone, etc. If we were to take off the top of our skull and expose our brain, we're going to get a really good view of the sphenoid bone if we do that. Of course, we'll have to actually remove our brain if we're going to want to actually see the sphenoid bone. So what we're going to do now is look at a superior view of our skull with the top removed and the brain removed. This view here shows the sphenoid bone really well. So here is the sphenoid that we're outlining. Some people think it looks like a butterfly or a bat, and that's the sphenoid bone. And there's a very prominent sort of saddle or groove in the middle of the sphenoid bone here, and that's called the sella turcica. Sella turcica is like a little saddle where your pituitary gland sits. And so the pituitary gland is located in that sella turcica. Again, just pointing out, there's our occipital bone, our temporal bones, the foramen magnum you can see there. Don't forget, you can see a little bit of parietal bones on the side. The frontal bone, very prominent in the front. The next bone we're going to learn is the ethmoid bone. Now, the ethmoid bone is a new bone. It's also really hard to see until you learn it. Then it's easy to see, but at first it's sort of difficult to find. I just think of it as it has to do with nasal stuff, nasal cavity. So one of the places you can see is the same superior view. Again, the brain's been removed, and we're circling that little tiny part of the ethmoid bone which is exposed. The part of the ethmoid bone is called the cribriform plate of the ethmoid bone. The cribriform plate has all these tiny little holes where olfactory neurons go that allow you to smell. Those olfactory neurons are actually connected to your brain. So if you think about it, you smell when particles enter into your nasal cavity. Those little particles and chemicals bind to actually endings of your little neurons, and those little olfactory neurons pass through that hardened ethmoid bone. The part is called the cribriform plate. Another place you can see your ethmoid bone really well is the upper portion of your nasal septum. So your right and left nasal cavity is divided. Your nasal cavity would just be one giant room, but instead it has a wall down the middle. That's called the bony nasal septum, which divides it into a right half and a left half. And the top of that bony nasal septum is our ethmoid bone. All right? The bottom half of that bony nasal septum is called the vomer bone. So the vomer and the ethmoid together make up what's called the bony nasal septum. It's why your nasal cavity has a right and a left side. The ethmoid bone also makes up the medial wall of your eye socket. It's kind of hard to see there, but we'll see it from some other angles. So it makes up the side wall of your eye socket. Okay, where else can we find some ethmoid bone? If you look at your nasal cavity, there's these little shelves sticking off the sides. The middle nasal conchae, plural, the middle nasal concha and the superior nasal concha are made of the ethmoid bone. The inferior nasal concha is actually a separate bone. So that can be confusing sometimes. If you're wondering where is the superior nasal concha, well, it's kind of hidden and you can't see it on our skulls, but you can certainly find the middle nasal concha and the inferior nasal concha. And those are pronounced, if you believe the dictionary, concha, but I think Spanish sounds more like concha, so I say concha and conche. All right, so we already found the inferior nasal conchae. Those are those lower ones. We also found the vomer. The vomer one's easy to find because it's that bottom, maybe 1/3 of the bony nasal septum dividing your nasal cavity. Some of these other bones we've already know. I wanted to point out the maxilla and the palatine bones. Here's an x-ray, and I was just pointing out your spinal cord back there, going through the different vertebrae, connecting up through the occipital bone. But here's what I really wanted to show you was the maxilla. So remember, the maxilla makes up the roof of your mouth. The mandible is sort of what you'd think of your lower jaw. There are also some sinuses, which are air-filled pockets inside some of our bones. The most famous might be the frontal sinus and the maxillary sinus, or maxilla. So they have sinuses. We can talk more about that. If we look at this inferior view again of our skull and we remove the mandible, we can see where our upper teeth are attached. That roof of our mouth is called the hard palate. So again, we're looking at the upper teeth there. That hard palate, or the solid roof of your mouth, is made of bone. Most of it is made of the maxilla. And because this maxilla is made of two fused bones, sometimes you'll hear people call them the maxillary bones. And then these two little pieces stuck on the back are the palatine bones. So together, the maxilla, the fused maxillary bones, and those little palatine bones make up what's called the palate, or hard palate. Sometimes those maxillary bones don't fuse, and that can lead to a condition called cleft palate. Cleft palate's a fairly common developmental structural issue where the maxillary bones don't fuse. So if you've ever heard of cleft lip or cleft palate, it's an incomplete fusion of the maxillary bones during development, and probably includes those palatine bones as well. If you're wondering how is that fixed, surgical repair can then close off that. Basically, your oral cavity and your nasal cavity are conjoined or attached and communicating, and so it needs to be closed off so you can talk, breathe, swallow, and things like that normally. So that was the hard palate. And finally, I wanted to end with a couple of smaller bones. The nasal bones are right there, sort of what people would maybe consider the bridge of their nose. So the nasal bones are easy to find. They're right there centered above the nose. There's two of them, the two nasal bones. The next bone I wanted to point out is called the lacrimal bone. The lacrimal bones, to understand sort of their role, we have our eyeball and a lacrimal gland that makes tears. Those tears then wash over and lubricate your eye, and they can drain into a tiny little hole in the lacrimal bone, and then they drain through a duct all the way down into the bottom of your nasal cavity. And so that's how your tears can actually drain into your nasal cavity. And sometimes when you cry, you might get the sniffles. All right, well, back to the lacrimal bone. So the lacrimal bone is located right there in the medial eye portion, a medial portion of the orbit, and it's got a little hole in it. So if you're looking for the lacrimal bone, look for a sort of small rectangular bone with that little lacrimal opening for your tears. And again, it's found in the eye socket or orbit. Just to review the bones of the orbit, the frontal bone is the top or roof of your orbit or eye socket. The sphenoid bone we mentioned is the posterior portion of the orbit. It's got those cracks and crevices and holes for arteries, nerves, and veins to your eye. The ethmoid bone makes up the medial portion of our eye socket, right behind that lacrimal bone. You can see it really well there. That's the ethmoid bone. So we've got lacrimal, ethmoid, sphenoid, and frontal. And then we can add the maxilla, basically is the floor or the bottom of your eye socket. So the maxilla is actually a really big bone. It goes all the way up there. So even though it has your upper teeth, it goes all the way up towards your eye. And then on the side, the lateral wall of our eye socket is the zygomatic bone. So there you can see the zygomatic bone filling in the side of the eye socket. All right, and then we put an eyeball in there. You can see how that all works to sort of make the border of the room that holds your eyeball, the eye socket. Okay, next, paranasal sinuses. I think I mentioned it. They're air-filled sort of cavities within the bone, and they're continuous with your nasal cavity. So if you ever have a sinus infection, it probably spread from your nose to your paranasal sinuses. And then we've also covered the hyoid bone. The hyoid bone floats above your larynx in your neck, kind of at the base of your jaw. So that covers all the advanced bones with the skull. And so you'll have time to go ahead and label those in your lab manual if you pause or use your textbook. This is a little more advanced, and so what I wanted to see if we could label when we actually do a sagittal cut through the skull and still have the tissue in place. So then it gets a little harder to see the bones. So we're just drawing them in. You can pause these if you want and look at them. I'm going a little too fast to name them all, but you can see the roof of your mouth is the maxilla and palatine. We can see our mandible in there going through the skull. We've got the big bones like the parietal bones at the back, the occipital bone. We've got little bones like the ethmoid bone. You've got to look between your brain and your nasal cavity. There's that little ethmoid bone. The ethmoid bone also makes up, besides the cribriform plate, it also makes up the superior middle nasal conchae. So we can see those there. Again, remember, ethmoid is nasal cavity. And then a separate bone all by itself is each inferior nasal concha. Sandwiched in there underneath our pituitary gland is our sphenoid bone. Again, when you do a sagittal cut, you really see the sinus of the sphenoid bone. And you can see your pituitary gland sitting in that sulla turcica. And if you can find the hyoid bone in there, you're doing really well. The hyoid bone is sort of a U-shaped, and when you cut it sagittally, you just see that little part of it there above your larynx. And just keep in mind some of the soft tissues in there, our tongue and our brain and our spinal cord are all pretty easy to see. So again, learning the bones within the sagittal cut's a little more advanced. Okay, continuing on, advanced skeleton, vertebrae, vertebral column. So again, we've already learned the 7 cervical, 12 thoracic, and 7 lumbar, but we haven't learned specific ones. Well, C1 is called the atlas, and C2 is called the axis, and these articulate together to give you kind of a swiveling when you do a no motion, sort of like a ring on a little peg. And you can see it over here in the x-ray. You can see the atlas C1 and the axis C2, and you can see how it swivels around. The way we name the rest of our vertebrae is a lot easier. We just name them by number. And you can see C7, C6, C5, C4, C3, building on up, C2, C1, and then C1 articulates with our occipital bone. Our occipital bone in C1 gives us our sort of yes motion versus the swiveling of C1 around C2 gives us that no motion. Also, you can see intervertebral discs on this x-ray and on this diagram. Remember, those are little cartilage discs or cartilage pads that cushion between the vertebrae. So, again, the way we name the rest of our vertebrae is just based on their position. We might call the 5th lumbar vertebra L5 or the 12th thoracic vertebra T12, and we just name them as they go. So hopefully that's something you can practice, and no matter which one I point to, you can label it or name it. Okay, next what we're going to cover is the parts of a vertebrae, or a vertebra. First we're drawing our spinal cord in there. Okay, the parts of a typical vertebra. So vertebrae are pretty famous bones, so they have maybe like 4 or 5 basic parts for each of them. And so we're going to learn those here. So here's a typical cervical, lumbar, and thoracic vertebra. And these are kind of how most of them look in that category. Because they all vary a little bit. Every vertebra has a body. The body's the thickest weight-bearing part. Obviously, the biggest bodies will be found on the lumbar vertebrae since they hold most of your body weight. The bony, prominent part poking to the back, posterior, is called the spinous process. So the spinous process is easy to feel. So if you're kind of push your fingers along somebody's back, what you're actually feeling is those posterior poking spinous processes. Right? So the bodies point forward, the spinous processes poke backwards. The transverse processes, you have one on each side of a vertebrae, those poke to the sides. You can't really feel those, but we're sort of coloring those in here. Things like muscles and ligaments and things will attach to these. And then if we want to complete the entire ring, we got to add these flat sheets. The flat sheet is called a lamina on each side. So those are the basic parts. And the lamina are kind of famous because sometimes you'll have to have a laminectomy to create room because your spinal cord or some of the nerves are being impinged, and so they'll do a laminectomy to create space. So the final part I wanted to mention was the vertebral foramen. Again, foramen means hole. Vertebral foramen means hole in the vertebrae, and that's where your spinal cord runs up and down the spinal column. or vertebral column. All right, so when you stack all those little vertebrae up, don't forget that there's an intervertebral disc between most of the bodies, and then you also create that, that hole there. It becomes a tunnel when you stack them all up for your spinal cord. We know the sacrum and the coccyx. Let's mention a little bit about the ribs, and then we'll follow up with the scapula. So if we think about ribs for a minute, there's 12 ribs. Everybody's got 12 ribs. The ribs are connected to our sternum through costal cartilage, or if you just want to remember cartilage, and that cartilage adds some flexibility to it. The first seven ribs are actually attached to the sternum through its own cartilage attachment, and so often we'll call those true ribs. So 1 through 7 are true ribs, and if you're wondering why the next ones are called false ribs, well, they're attached to the cartilage of rib 7, so they're still attached, but they have kind of shared cartilage. And there's a couple of floating ribs, 11 and 12, because they don't attach to the sternum at all. If you look at a vertebra, and specifically if you look at a thoracic vertebra, you'll notice that ribs attach. So our ribs actually go from our thoracic vertebrae to our sternum, and again, they connect to the sternum through cartilage, and that basically creates your rib cage. And so if we draw in another rib on the other side, you'll see how you actually create the thoracic cavity, or the thoracic cage or chest cage. And in there, protected, are things like your heart and your lungs, and remember we learned pericardium and pleura and all that sort of stuff. So rib cage is basically the thoracic vertebrae, the ribs, and the sternum. I just wanted to point out a little bit about the connections there. Your clavicle connects to your sternum on each side, and so that creates a joint, and then the clavicle is then attached to your scapula. Your scapula is then attached to your humerus, so a lot of this is all sort of funneled through this joint between your clavicle and your sternum. Okay, let's jump back and look at that scapula in a little more detail. So the scapula is one of my favorite bones, so we're going to learn a couple parts of the scapula. And so remember, your scapula, you kind of poking out there, but most of it's behind your ribs, actually posterior to your ribs. And we look at the x-ray here, we're going to outline the scapula, and you can also see the humerus and the clavicle in this x-ray, and of course the ribs are in front of it. So our scapula has some prominent parts. One part is the acromion process, and the acromion process basically is this part that sticks off the scapula up. And so you can actually feel this on the outside, sort of lateral part, upper part of your shoulder. The other famous part of your scapula is the glenoid fossa, and if you want to think of that, it's kind of like your shoulder socket. So the glenoid fossa actually helps hold the ball of the humerus, called the humeral head. And so we also have all these muscles and tendons that come around, called the rotator cuff tendons. And we're not going to learn those muscles much this semester, but they come around your humerus right under that acromion process, and so that can cause some pain. You may have heard of a shoulder separation and a shoulder dislocation, so I wanted to talk a little bit about what are we talking about there. And so two different things, and we'll start with the separation. So a shoulder separation is when your clavicle separates from the acromion process or other parts of the scapula. So a shoulder separation is when the humerus actually pops out of that cavity. So here you can see it is not separated, but it is dislocated. So remember, if you think about it, you just have to keep track of, well, shoulder separation is the clavicle and scapula. Dislocation is the humerus and scapula. Okay, next we're going to do the bones in the hand. And so you might want to pause this depending on how fast you want to go. So we're going to actually look at the bones of the hand. And we're always going to start with our right hand with our palm up. So that's the anterior surface of our right hand. And once we learn that, we could always transfer that over to other angles or other hand. Let's start with the metacarpals. The metacarpals are named number 1 at the thumb, going all the way to number 5 at the pinky. We see our carpals in there. We can also name the phalanges, the proximal, middle, and distal phalanx. Or if you say phalange, that's fine, but phalanx is singular for phalanges. So if you were to break your metacarpal 5, you would know immediately that's the pinky side. That 5th metacarpal is that's also often called a boxer's fracture. You ruin that when you punch people. Okay, now we're going to go through the carpals. The first one is called the scaphoid. Next is the lunate. Then triquetrum. I always have trouble spelling that. Triquetrum, or if you want to spell it, triquetrum. Next is the little pea called the pisiform. Looks like a little ball or a little pea. And then we'll start the next row of carpals. The first one is trapezium. The next one is trapezoid, followed by capitate. And that's probably the biggest one. And then the final one, it has a little hook on it, is called the hamate. And so there you can see in the x-ray is the hamate. And you can even see the little hook on the x-ray. So those are the carpal bones. And to memorize them, people came up with memory tools, if you've ever heard of a mnemonic before. And so the mnemonic is Sally left the party. So this tells us the first letter of each bone, carpal bone, and also the order. So Sally left the party to take Kathy home. It's important if you use this mnemonic that you remember you always start on the thumb side proximal and then go distal, and always start on the thumb side to pinky side. So proximal, thumb to pinky, and then distal, thumb to pinky, and that'll tell you. Again, it only tells you the first letter and the order. You've got to still memorize the names. So if you think you're a carpal expert, if we look at an x-ray, we can see our radius, we can see our ulna. If we do Sally left the party to take Kathy home, the first one that looks broken there is Sally, so scaphoid. And then we can actually see the repair. It looks like they put a pin or a screw in there. The other thing is if you can find the hook, you can always find hamate. And so again, if you just remember a few of them, you can always kind of plug in the other ones, like capitate's really, really big. And if this is making sense to you, you can always pause and rewind it. Then maybe you're ready to be a radiologist and make lots of money. All right, we've got the coxal bones down, I think. And so remember the parts of the coxal bones. If you've heard of a broken hip before, you might be wondering, is that actually the coxal bone that's broken? Is it the ilium? Is it the ischium? Is it the pubis? Well, usually when people break their hip, it's actually the femur that's actually broken there. And so here we can actually see the neck of our femur. It has a fracture in it. The head is the little ball. The greater trochanter is this little part that sticks out to the side. So remember, the acetabulum is the hip socket. And that can sometimes get injured in a broken hip, but usually the problem is going to be the femur. You can even see the pubic symphysis on both of these x-rays. It's just nice. So most of the time when someone gets a broken hip, it's going to be somewhere on our femurs broken. Less often, it might be some of the acetabulum or the actual coxal bone. Just since we're looking, I wanted to point out the greater trochanter. The femur is this very prominent ridge to the side, some very big muscles attached there, and it sort of makes that big lump. So the lateral lump on your femur is called the greater trochanter. You can see it here. And sometimes you'll hear about hip fractures as intratrochanteric or subtrochanteric, all referring to that greater trochanter. Right, so again, both of these x-rays show a broken hip. Next, we've got our patella, which we know is our kneecap. Just, again, parts of the femur, we got that. So the kneecap, we know our patella. I wanted to focus a little bit on the tibia and fibula, because you probably know those bones, but you may not know these parts of it that form the ankle. So again, our patella is our kneecap, our femur up there. Our tibia is always the medial bone, bigger. The fibula is lateral. So the fibula down at the ankle has this very prominent sort of rounded part, which a lot of people would call their ankle bone, but it's really called the lateral malleolus, lateral being out to the side. So it's the lateral malleolus, which is part of your fibula. And that part of your fibula likes to break. So you may roll your ankle while playing soccer, and that can cause a fracture of your fibula pretty easily. Just rolling your ankle. Putting a lot of weight on that fibula breaks it. The tibia, the ankle bone at the on the tibia side, is called the medial malleolus. Medial because it points towards the center line of the body or midline of the body. So the medial malleolus of the tibia is your ankle bone on the inside of your ankle, and the lateral malleolus is the outside of the ankle. I wanted to point out one of the tarsal bones, the talus, since the talus actually helps form our ankle with our tibia and our fibula. The talus is one of the tarsal bones we'll learn in a few minutes. Of course, if you've ever heard of a tib-fib fracture, that's obviously a more serious break. It can happen more distal at the ankle when you have a more serious injury to your ankle. Obviously, that's a pretty painful break when you've broken both of those bones. All right, let's focus on the foot and learn some of those tarsal bones. The tarsal bones that we're going to learn is really just two of them. So the tarsal is this group of bones, and we're just going to learn two of the big ones. So we've got our talus and our calcaneus. So the talus is the one that sort of attaches to our ankle, our tibia and our fibula. The calcaneus is our heel bone. So again, the tarsal bones are all of those. We're not going to learn the names of the other tarsal bones. You could if you wanted. I think there are 7 or so. The two that you have to know for our class, the talus and the calcaneus. Again, on this x-ray, you can see the tibia and the fibula, and you can see the talus right underneath them, making your ankle, and then your heel bone, the calcaneus. All right, so you may have heard of your calcaneal or Achilles tendon or calcaneal tendon, which attaches to your calcaneus. We've got metatarsals. Again, they're named 1 through 5, just like your metacarpals. The big toe is metatarsal 1, and then the pinky little toe side would be metatarsal 5. So metatarsal 1 is always on the big toe, and then we've got phalanges, just like our fingers and our toes. And if you check out this x-ray of someone in high heels, you can see how the bones of the foot really are sort of oriented, so all your weight goes down those metatarsals in a way that's not natural. Usually you would have all your weight on your calcaneus and probably metatarsal maybe 5 by your big toe normally. Page 96 and 97, if you're feeling like a bone expert, you should definitely be able to answer these questions. They'll definitely show up on your quiz. So, for example, list the bones that make up the orbit. That's your eye socket. Just think of it like a square room, and you've got to have a roof and a bottom. And you can try the rest of these. If you have questions about these, we can talk in office hours or before lab. Finally, we wanted to finish up with joints. I wanted to point out that 8.2 movements at the joints, we're going to wait and do that with the muscles. So we're just going to focus on types of joints, and we'll look at some examples of joints, the knee being a famous one. No E in famous. So knee is a famous one. We're going to learn the parts of the knee. So again, follow along in your lab manual. There are some immovable joints in our body. The most famous ones are probably the sutures in our skull. So you may think of your skull as just one giant bone, but we learned the individual bones, and the individual bones are actually joined together. Remember, bone to bone is a joint. In this case, though, they're fibrous joints that do not move, so they're fibrous collagen connective tissue which glues them together. Another famous immovable joint would be your teeth. Your teeth are embedded in your mandible and maxilla, and they shouldn't really move at all because they're in these fibrous joints, again, held in place by these little ligaments. And if your teeth move, maybe it's time to go see your dentist. Slightly movable joints, and I mean slightly movable because you can barely tell that they move. Probably the most famous ones are the pubic symphysis and the intervertebral discs. So these involve cartilage pads. So the pubic symphysis is the joint between two pubis bones. Remember, a joint is just a joining of two bones together. So the two pubis bones are actually joined at the pubic symphysis by this cartilage pad. And there's a little bit of movement there, especially during childbirth. That loosens up a little bit. Probably more famous are the joints between the vertebral bodies, and the vertebral bodies are separated by a little intervertebral disc of cartilage, and they have slight movement. And you might be thinking, well, wait, I can move my back a lot, but when you bend forwards and backwards, you really only get a slight amount of movement in maybe, I don't know, however many joints you have. A dozen or so of these joints at any one time are moving. And so these are only slight movement. If you twist and turn, those are different joints. When you swivel your spine, those are movable facet joints, which we'll learn are called synovial joints. So that takes us to what are called freely movable joints, all of them are considered synovial joints. So you'll have to remember that word, synovial joints. They range from a lot of movement to just slight movement, depending on which joint. Most all the joints we notice and that we're familiar with are considered synovial joints. So your hip joint, our phalanges, our jaw, our shoulder, our elbow, our knee, our wrist. To some degree, all of these are synovial joints with free movement. Some of them just glide a little bit, like you may not notice your sacroiliac joint moving much, but it glides enough to be considered a synovial joint. So synovial joints, again, joints are just things between two bones. Synovial joints have some specific parts, typical parts. So we take our two bones and we want to make a synovial joint. We cover those bones, like always, cover them with periosteum. When the periosteum approaches the ends of the bone, instead of having periosteum, we have articular cartilage. So the articular cartilage is going to cap our bones in the synovial joint. We also have a tough fibrous connective tissue cover called the joint capsule. The joint capsule surrounds the joint. It's pretty much an extension of the periosteum, so it's tough collagen connective tissue. Then so in addition to the articular cartilage, we're going to fill that space in our joint capsule with synovial fluid. So synovial fluid helps cushion and lubricate that joint and protect it. All right, keeps your joint happy. So that's the typical synovial joint. Again, it has movement, quite a bit of movement. We can do some add-ons. Maybe you want to use some ligaments to stabilize that joint. Some ligaments can be in the joint capsule, others are outside the joint capsule. We can even sometimes put in a cartilage pad within the synovial joint, like the meniscus in your knee and the labrum in your shoulder. We can also, of course, have tendons that stabilize our joints as well. Tendons and ligaments can have these little sacs, these little fluid-filled connective tissue sacs called bursa. Again, we don't have a lot of time to learn too much about all of these structures, but you may have heard of them. There's often adipose tissue around our joints too to help sort of cushion things as well. All right, so synovial joints are most of the joints that we think about in our body. I just wanted to point out some examples: the sternoclavicular joint, the glenohumeral joint between your humerus and your scapula, the acromioclavicular joint as well. For our class, you can just remember, well, hey, that's the shoulder, but as you get more advanced in anatomy or in your career, you may learn some specific examples of these joints. The elbow is actually the humerus and ulna, as well as the humerus and radius, and the ulna and the radius all joining together in complex ways. There's the sacroiliac joint, which you probably don't notice a lot of movement in there, but it's in your pelvis. The hip joint is actually the femur with the acetabulum, is the joint there. The temporomandibular joint is your jaw, between your temporal bone and your mandible. And of course, all the little vertebrae have complex joints between them too. So for our class, we're really just going to focus on the knee, but I wanted to point out that if you know the two bones, you can figure out the joint. The knee is made up of the femur, patella, and the tibia, not really so much the fibula. And the ankle is made up of the tibia, talus, and fibula. We're going to focus in on the knee since the knee is the most famous and a lot of people injure their knee. We're going to learn the parts of the knee as an example. So here in your lab manual on page 102 is the diagram of your knee, and we're going to go ahead and label these parts. And you can also check out the MRI. Shows both a frontal and a sagittal view of your knee. One of the things we need to do is to remove the patella so we can actually see. So I wanted to point out your patella, remember, is sitting right there. We're going to move our patella over so that we can actually see inside the knee. So this is our right knee. There's our patella. We're going to cut the patellar tendon and patellar ligament. We're going to cut it and move it back away. So this is an anterior view. Note your tibia and fibula and your femur. The tibia is obviously medial and the fibula is lateral. And so we're actually looking, we're looking at our right knee. Since we're looking at our right knee, our fibula is lateral and our tibia is medial. So that's going to help us name some structures. For example, this collateral ligament is called the lateral collateral ligament. This other ligament, since it's on the medial side, is called the medial collateral ligament. Some people just call it the MCL. We can also name those cartilage pads in our knee, the lateral meniscus and the medial meniscus. Again, those are cartilage, so when you damage those, it's kind of tough on your knees. We also have our patellar tendon and our patellar ligament. When I was a student, we used to just always call it the patellar tendon, but by definition, you should probably call the upper portion the patellar tendon and the bottom portion the patellar ligament. Basically, this is the tendon that comes from your big, strong quads, goes across your patella and down to your tibia, and allows you to do things like knee extension. So your quads extend all the way down through your patellar tendon and patellar ligament. Again, if you just want to call it your patellar tendon, that's fine too. Okay, probably one of the most famous ligaments is the ACL, the anterior cruciate ligament. The anterior cruciate ligament crosses your knee, and it actually attaches to the anterior tibia and goes and crosses to the back of your posterior femur. So it's named by its attachment point to the anterior tibia, so anterior cruciate ligament. And if you look from the side, you can actually see how it crosses front to back across your knee. So I always remember a cross, crucifixion. If we look at our posterior cruciate ligament, the posterior cruciate ligament goes from the posterior tibia and crosses to the front of the femur. So together, these two ligaments help stabilize your tibia and your knee in forward and backwards motion. The ACL often ruptures or tears, and when it ruptures or tears, then you have to have it repaired. Of course, your knee would have reduced stability when it's damaged. If you have a really bad knee injury, sometimes you'll damage your ACL, your MCL, and your medial meniscus all together. And so you can see that's a lot of stuff that would be damaged. If you notice the MRI, you can probably pick out some of the bones, the femur, patella, and tibia, and the femur on top and the tibia on the bottom. And you may even be able to pick out the black or dark spots are usually the ligaments and cartilage. Here's an actual MRI of a knee, and so again, this is a sagittal view, a side view, and as we scroll through the images, you can see the knee bones. You can even sort of make out some of the ligaments, I guess, are black, and the cartilage, I believe, is sort of black and dark. Pretty sure this person had an injury, so maybe the ACL was torn or something like that. Okay, we're going to stop there. We're not going to go any farther than 8.1. That is the end. See you guys.